Family mode.
I'm Susan Kaufman. I'm here for Attitude Magazine, and you are listening to Attitude's ADHD Experts. Today's topic is oppositional defiant disorder, short form ODD. Angry outbursts, rudeness, hostility, defiance. These are the hallmarks of children with ODD, and it's one of the most difficult aspects of parenting a child with attention deficit disorder, and one that causes the most heartbreak among the parents in our community here at Attitude. I'm very pleased today to welcome back Bill Dodson, a board-certified adult psychiatrist who has specialized for almost 30 years in adult ADHD. Dr. Dodson is currently in private practice in Denver, Colorado. He's a life fellow of the American Psychiatric Association and the author of the forthcoming book, What You Wished Your Doctor Knew About ADHD. Today, Dr. Dodson will talk about strategies for managing oppositional defiant disorder in kids, in adults, and in the family, including some of the new information that we have about medications for ODD. Dr. Dodson, thank you so much, as always, for joining us. We are very grateful for your time.
Thank you very much for inviting me.
Before I turn it over to Dr. Dodson, just let me mention a few of the usual housekeeping items and answers to the frequently asked questions. Please post your questions in the box on your screen. Dr. Dodson will give an introduction to the topic through his slides, and then he'll take as many questions as we have time for. If you have problems hearing us or if the broadcast breaks up, it's most likely your internet connection. So in that case, your best solution is to dial in via your phone line. After our sessions, as always with Attitudes webinars, you'll find Dr. Dodson's slides as well as the audio of this broadcast on the Attitude website. It's at attitudemag.com/webinars. And on Friday, you'll also find the audio of this webinar as a podcast in the iTunes store in the ADHD Experts audio series. As I've asked before, if you do enjoy our podcasts on iTunes, we would be so grateful if you'd add a positive review. So with that, let me turn it over to Dr. Dodson to go through his slides and keep those questions posted in the right, and we'll tee them up as soon as he finishes his introduction. Thank you. Over to you, Dr. Dodson.
Thank you, Susan. Thank you very much for coming in and attending this webinar. We're going to be talking today about oppositional defiant disorder, ODD, and to some extent its worse, more impairing cousin, conduct disorder. Oppositional defiant disorder becomes conduct disorder about 40% of the time. And so it's commonly viewed as kind of a starter version of conduct disorder, and we try and do everything in our power to keep it from migrating into full conduct disorder. It's important to note that this is a lot more than just a misbehaving child who doesn't listen to his mother. This is a very well circumscribed genetic neurological condition in which the child is hardwired to defy anybody that they perceive as being in authority or telling them what to do. This is not the type of child who responds to the parent training to be a better parent or providing more structure. Oppositional defiant disorder is extremely common, and depending on who you read, it's anywhere from about 10% of males and 9% of females to as high as 25% if the person also has ADHD. Oppositional defiant disorder and ADHD co-occur almost all the time. It is exceedingly rare to have an ODD child who doesn't also have ADHD. There's a grand total of 18 such cases reported in the literature, so it's exceedingly rare. The reverse is not true. Not everybody with ADHD has ODD. Somewhere around 25% of boys and about 11% of girls who have ADHD will also carry an ODD diagnosis. These are totally separate conditions. They're both genetic, both have an independent transmission genetically, but they are very, very different conditions that require separate complementary treatments. First of all, the diagnostic criteria for oppositional defiant disorder. You have to have 4 out of 8 different criteria, present at least 6 months, and unfortunately they don't give you real good cutoffs. They use the word often, and nobody really knows what often really means, which accounts, this is what mostly accounts for that wide variety in how prevalent it is. It's how that researcher defined often. But the 8 criteria are: often loses his or her temper, having temper outbursts, explosive, unpredictable behavior. Number 2, often argues with adults or anyone they perceive as being in authority. Number 3, often actively defies or refuses to comply with adults' requests or rules. Number 4, often deliberately annoy people, and this is usually their younger brothers and sisters. Number 5, often blames others for his or her mistakes or misbehavior. 6, often touchy or easily annoyed by others. 7, often angry and resentful. Number 8, often spiteful and vindictive. While these are the diagnostic criteria, they really miss, I think, the look and feel of what this condition is like. First of all, it has an onset. Many people will describe their children as being fairly normal children, willing to comply with rules and things like that and get along with others. And then fairly suddenly, these symptoms appear and are there all the time. There's a childhood onset somewhere around age 4 or 5. There's an adolescent onset right after puberty. And the development into sexual beings and having sexual hormones is thought to have some role in its emergence. You also have to remember that because ODD is so very heavily genetic, it runs in families. So almost always there is somebody who's a first-degree relative who also has oppositional defiant disorder. Very commonly, it's a parent, and this is one of the most common causes of divorce in ADHD families, is that the non-ADHD, non-ODD spouse just can't live like that anymore, where they're getting it both from their children and from their spouse. You can usually see this in divorce families because the divorce is never finalized. It's a never-ending divorce litigation, not so much to win, but as to thwart the non-ODD partner. And that's the important thing to identify with kids with ODD or adults. The oppositional defiant disorder child is hardwired neurologically, genetically, to oppose, defy, or thwart the wishes of anyone they see as having power. It's important to emphasize over and over again, their goal is not to win. Their goal is to defeat you. And so consequently, they will suffer huge negative consequences just to defeat you and make you frustrated. This is why traditional better parenting skills and structure have never once shown any benefit for this group of children. It's that they really don't care what you're doing. They don't care about rewards. They don't care about punishments. They are hardwired to make you feel utterly powerless and frustrated. Their goal is to defeat you, to thwart you, not to win. Therefore, just as ODD leads to divorce, it also leads to adolescents being thrown out. These are kids who don't get along with anybody in authority, whether it's teachers, coaches, policemen, certainly their parents. And they end up being what is called here in Denver, throwaway kids. If you go down to your downtown section, you will find a street that is lined with early to mid-adolescent children who've been thrown out of their houses. Virtually all of these kids have oppositional defiant disorder. Their presence in the home has just become intolerable, and oftentimes the parents are led to the choice of either choosing to have a place where the other children in the family can grow up without constant bickering and fighting over the ODD child. About 40% of the time, ODD progresses into what's called conduct disorder, and this has all of the previously listed symptoms for ODD, but now it actually is causing physical or emotional harm to other people. It involves stealing, it involves torturing the family pet, really disturbing types of things. About 40% of people with conduct disorder go on to antisocial personality disorder. This is one of the reasons why 40% of people of males who are currently in the prison system will meet the diagnosis for both ADHD and conduct disorder. Having ADHD does not increase your risk of ending up in jail. It's almost entirely due to the oppositional defiant conduct disorder symptoms that go along with the ADHD. So there are very dire consequences of not intervening, not doing anything, hoping that the kid will grow out of it. While there are these dire consequences in research, somewhere around 22 to 27% of children do just as miraculously as they started having ODD symptoms, suddenly they stop. And again, no one has an explanation for this, but somewhere around 1 in 4, the syndrome remits. But again, that's much less than the 40% that go on to more severe illness, and about 30% of people who continue having the oppositional defiant disorder their entire lives. There has been virtually no research at all on adults with ADHD. I was able to find 2 studies anywhere at all times, even in foreign language, that address the existence of ODD in adults, but it is certainly there and it persists into adulthood about 70% of the time. You can certainly understand why nobody wants to study these kids, because their research subjects are out to thwart anything that the researcher wants to do. And no person in their right mind is going to want to study such a patient population. As I said earlier, traditional behavior programs don't work, since the identified patient is hardwired to defeat anything that the parent tries to do. Currently, there's very little in the literature, especially in the United States, on how to manage ADHD and ODD children in the house. Virtually all of the literature comes from either the Netherlands or Sweden. There they have done a great deal of at least genetic research on these individuals. Here in the United States, we tend to be a very judgmental, punitive people. We tend to, whether we're individuals or even the court system, tend to view oppositional defiant disorder as either being bad kids, bad parents, or both. In Europe, however, there are numerous studies, most of them out of the Netherlands, looking at children adopted at birth who later on go on to develop oppositional defiant disorder. And what they found was it follows the genetics, not the upbringing. It's an almost entirely genetic disorder. There are 2 articles out of the University of Uppsala in Sweden, unfortunately not in English, that looked at the cerebrospinal fluid of adolescents and adults with oppositional defiant disorder, and they found that these individuals had no metabolites of a neurotransmitter called serotonin. Serotonin is a neurotransmitter that when it's released actually keeps the next nerve from firing. It's an inhibiting, quieting, problem-solving side of the nervous system. When they tried, though, to enhance serotonin with these people, what they found was that the oppositional defiant disorder either didn't change at all or got worse. There was not a single case in which it got better. So, based on some somewhat fallacious logic, they decided that since ADHD individuals had a paradoxical reaction that when they took stimulants they calmed down, they tried blocking serotonin. And what they found when you lump all the studies together is that about 75% of people with oppositional defiance disorder got rapidly better. And in some cases, the ODD went away entirely. So again, we have absolutely no explanation about why these medications work. There are no medications available in the United States for an indication of oppositional defiant disorder. The FDA is one of those organizations that views oppositional defiant disorder as bad kids, bad parents, or both. And so they deny the existence of oppositional defiant disorder. So they will never allow a company to actually bring a medication to market for the treatment of oppositional defiant disorder. It's one of those policy things that ignores reality. So what we found that works is fairly straightforward. The first thing to do is to treat the ADHD. When you adequately treat the ADHD with stimulant medications, the symptoms of oppositional defiant disorder decrease about 50%, making this much more manageable. But the ODD is still there. Then the next thing to try is a low-dose atypical neuroleptic. These are not, again, indicated at all for ODD and are used for usually mood disorders or schizophrenia in adolescents or adults. The ones that have a literature that actually show that they work are Abilify, omeprazole, aripiprazole, or spiridone, and olanzapine. Seroquel can also be used, but there's also nothing in the literature to support its use. Again, all of this literature is from places outside of the United States. Most of it is not in English. But when these medications do work, they work very quickly, a matter of 3 or 4 days, and they work very dramatically. The typical thing is for me to get a phone call about 3 or 4 days in from a mother who calls and says, "Doctor, someone has come and taken my child, but they left another kid here that looks exactly like him, only he's nice to me." That's the level of response that you should expect. If you don't get that, you move on to the next neuroleptic. And really, all of them should be tried before giving up on the neuroleptic treatment of ADHD and or oppositional defiant disorder. But you're not out of the woods yet. Most of these kids have absolutely no skills about how to get along with other people. Indeed, they appear, when they have oppositional defiant disorder, as being very narcissistic people caring about themselves only, and they feel completely comfortable with doing horrible things to other people without any apparent pang of conscience. So once you actually have somebody who's not actively trying to defeat you, you can do some of the techniques that do work with non-oppositional defiant children. On the Attitude website are a number of articles by Dr. Ross Green from Harvard, and his book, The Explosive Child, tends to have a number of these techniques in them. The standard texts are for the childhood onset, in other words, pre-pubertal, less than 12 years old child. The book to get is The Defiant Child by Russ Barkley. And you can get that from the online addwarehouse.com bookstore. This is one of the few textbooks that really helps you understand exactly how to provide structure for these very difficult, hard-to-love children. Barkley is very clear and emphasizes it many times in the book that this is not something that a parent can pick up and just implement themselves. Almost always, according to Dr. Barkley, they need somebody who's a child behavioral expert to help them, coach them, help them practice, and really implement these behavioral techniques so the child can learn how to live with other people. For adolescents, there's only one program that has shown any detectable lasting benefit, and that's the REST program, R-E-S-T, and REST stands for Real Economy System for Teens, and it is a highly behavioral program that is just imposed on the family system. What the parents do is they sit down and figure out how much it costs them to have the pleasure of their ODD child in their life. They then divide that by 365, and the adolescent has to do 5 things every day without being reminded. They have to keep themselves clean. In other words, they have to wash their own clothes, they have to shower, they have to be presentable. They have to keep their room clean and orderly. Out in real adult life, people who trash out the apartments they live in get evicted. In exchange for 3 meals a day and a roof over their head, they have to do a major chore, vacuum the entire house, cook a meal and clean up afterwards, something like that. And again, without being reminded. They have to avoid all aggressive or violent action, speech, or expressions, so even rolling their eyes at their parent, something that would get you fired from McDonald's if you did it to the boss, counts in that regard. And then finally, health and safety. No drug use, no staying out all night, that sort of thing. To be especially noted, school performance is not a part of the REST program. If the adolescent is able to do all 5 of these things without being reminded, they get that day's money in an envelope by the bed at the end of the day. If they miss even one of them, they get nothing. They just get an index card with what they missed on it. What this does is it gives the adolescent no one to defeat. If they want the money to do the things that are important to them, they have to learn what is always non-negotiably required of adults in order to live out in the world and get along with other people. This program is about 83% effective. So that's much better than 0. This is in the literature. There's also a book called The REST Program that's available on Amazon. So that's a very quick overview of a very thorny, difficult, but common problem found in children with ADHD. And it's not as hopeless as it at first appears to be. So with that, I'll open it up to questions.
Thanks so much, Dr. Dodson. Can we go back for a second to diagnosis? Some of the questions here relate to people whose children behave absolutely beautifully at school and or with outsiders, but behave in a very defiant manner with their parents. And there's a question as to whether that meets ODD, the criterion of ODD. Does it have to cross all boundaries, or can it just take place in certain settings?
That is a real source of argument in the few people that actually specialize in this and who help develop the diagnostic criteria. Under the old diagnostic criteria, you had to have impairment thwarting, oppositional behavior, outbursts of anger and stuff like that, both at home, in school, in church, on the playground. You had to have it everywhere. Now it is recognized that while that's a very common presentation, there are just as many kids who are only that way with their parents and can be just absolute darlings and well liked by teachers, coaches, and people like that. So while it's not an official thing right now, that's where the field is headed, is that you can have a very isolated place where these behaviors occur. And almost always it's with the parents.
Right. There's just several people. I'll just read one quote. If our son's only oppositional at home, can that still be ODD? And I guess you're saying yes.
It seems absolutely yes.
Absolutely yes. Okay. Another question that's come up about diagnosis is how does one differentiate oppositional behavior that comes from depression or anxiety or reaction to stimulant medications that make children angry? A number of people have said that the stimulant medications seem to make their children angry, and they're wondering if that's a separate issue from ODD.
That is a separate issue. Either the dose of stimulant medication is too high, or the anger is only occurring during the rebound period at the end of the dose. So it's usually very focused and very conditional. It only happens when he takes his ADHD medication, or it only happens right at the end of the dose. So either a dosage adjustment or adding another what we call step-down dose at the end of the first one that lets the kid come down without having the rebound phenomenon is a very quick cure for that type of behavior. Again, this is more than just an angry kid.
Right.
These are kids who have as their life goal, they put all of their energy into it, into annoying, thwarting, defying the person that they see as being in power and authority. That's the real thing I want you to take away. Every kid gets angry, every kid misbehaves, but this is a pervasive pattern, and again, focused in on just authority figures.
Okay. How about differentiating ODD from depression? That's people are wondering if it sounds very different from what you're saying. Depressive people are usually, if anything, more subdued, but wondering what you...
Yeah, I think they're identifying the same thing. When the average person on the street uses the term depression, they use it as being synonymous with being sad, blue, down in the dumps, that sort of thing. In point of fact, only 60% of people who are depressed ever report sadness. What is by far the most common emotional symptom in the syndrome of depression is uncharacteristic irritability. Usually these people are fairly easygoing, but now they're just rubbed raw, and they tend to kind of explode if you do something that irritates them. Again,
okay.
And it only occurs in the depression. Usually these are very low energy people. That's sort of the definition of what a depression is that all of the joy has gone out of life. They have no motivation, very low energy. They just want to withdraw into their room, that sort of thing. An oppositional defiant kid is going to come find you and tell you just what a terrible parent you are, curse at you. Again, it's a very active, aggressive thing that you can't even avoid these kids. They'll come looking for you to pick a fight.
Great. And a couple of people also are saying that their child is very angry and oppositional to one parent and not another, and they're wondering if that also could qualify as an ODD diagnosis.
Well, that's less common. It still qualifies under the new way of looking at, and if you were in Europe, that would certainly qualify you. Our Diagnostic and Statistical Manual number 5 is a very conservative document, and it's written almost entirely by researchers, actual practitioners who really have real-life experience with these disorders, make virtually no contribution to the diagnostic manual. It's more for researchers and statisticians than it is available and useful to practitioners.
Okay.
It is a diagnostic and statistical manual.
Right.
So,
turning now to treatment, some of the people on the webinar are treating their children for ODD and are wondering whether the non-stimulants, the Strateras and the Intunives, can help with both ADD. Sorry, they're treating their children for ADHD, whether they can treat ODD as well.
There's a grand total of one published study on that did show what they called a statistically significant improvement in oppositional defiant disorder with Stratera. I would suggest to you that that's very different from something that is clinically significant. Something that's statistically significant, only statistically significant, is something that neither you nor I would even notice. It just means that it's somewhat less likely to occur by chance, is what a statistically significant response is. What we want is something that really shows a dramatic difference out in the world. And so Stratera was not able to show that, but again, only one study.
Okay. So it's hard to know. We don't really know yet, I guess, is what you're saying.
The jury's still out.
Okay. In terms of, let me find the name of is it risk, what's the name of the atypical?
There are a number of atypicals
right.
that are out there. Probably Risperidone is the brand name,
okay.
Is the one that has been most used and most studied, but also is the one that the New York Times has a vendetta about.
Right.
And they, the week doesn't go by that they don't trash that medication in some form or another.
Right.
And if and when these medications have a dramatic benefit, and that's about 3 out of 4 of them, that's pretty good in any ballpark, it's going to be unmissable. It's going to be dramatic, it's going to be quick, it's going to be at low dose. So usually it's like 1 milligram of Risperidone given at night, and if it's not dramatically effective in 2 or 3 days, you stop it.
Okay.
There's very little downside risk to at least a brief medication trial.
Side effects, people are concerned about the side effects with Risperidone, especially a couple of people's children, doctors have cut back their dosage because of concern about side effects. Another person's child developed elevated blood sugar. Are there concerns about the side effects with Risperidone?
Sure. Every medication, aspirin, has side effects. One of the first things I would encourage a person to do is to literally list on a piece of paper what the risks are either of the treatment and non-treatment. What's the risk to the child, to the family unit, to the parents, to the marriage of not treating? That's very rarely looked at, especially by very anxious parents. The most common side effects with any of the neuroleptics is just sedation. The kid's a little groggy. Rarely, especially when you're using very low dosages, 2.5 to 5 milligrams of Abilify, 1 milligram of Risperidone, 2.5 to 5 milligrams of olanzapine, brand name Zyprexa. When you try these medications, usually it's a very low dose, very short periods of time, but the major side effect is one of sedation. The side effects are directly related to dose. So the higher the dose, the more likely it is for a person to have side effects. People can get stiff and their tongue can get stiff so that they have trouble speaking. That's called a dyskinesia. They can get very restless and almost march in space. Technical term for that is akathisia. In very, very rare cases, children can start lactating. It's very complex mechanism, but again, I've only seen that once or twice, and usually at doses 4 to 5 times what I just listed. And then it also can cause what's called a metabolic syndrome. Any of these medications,
that would be the blood sugar
right,
problem.
It can raise blood sugar, and also it can turn off what's called the satiety center, the section in the brain that tells you that you've had enough to eat, you're full, you're satisfied. So these kids just eat and eat and eat and eat, and they're putting on a pound or 2 a week. The nice thing is, you stop the medication, that goes away. None of these things are permanent.
So some kids just can't take these medications, and
Right.
family will have to move to the behavior modification strategies that you described.
Right.
Okay. Let me just see here. There are a couple of teachers on this webinar, it's interesting, asking for any thoughts on how to deal with oppositional children in the classroom. It's a tough question, I'm imagining.
That is a tough question. Mind if I think about it, dodge it for a few minutes?
Sure.
And let me think about it?
Yeah. In terms of therapy, should a therapist have a specific background in dealing with ODD children for cognitive behavior therapy?
That certainly helps.
Right.
And it's something I've been emphasizing over and over again. There are a lot of therapists out there who are very well trained, have nice programs and things like that, that essentially just make for a better parent and a more structured home life. We're talking about totally different kids. We're talking about kids who are hardwired to make the life of their parents a misery. They are there to tear down, demean, embarrass the parents. They come by 2 or 3 times every day to tell the parent just what an awful person they are, what an inadequate parent they are. Again, there's an attacking quality to oppositional defiant disorder and conduct disorder. And parents can take that to heart. Again, they say, well, am I a bad parent? I mean, is it some inadequacy in me that has produced this child from hell? The answer is no. Again, luckily, most of the time there are other children who are doing perfectly well. And that's sort of the validation of the parent that, their parental techniques actually do work with kids who don't have oppositional defiant disorder. So a lot of times, the parents need a lot of supportive, reality-based therapy and family therapy themselves. The real problem comes when one of the parents is oppositional defiant themselves. This is the person who also will be tearing down the non-ADHD ODD parent, refusing to go in for treatment, refusing to give the medication. Anything that the non-ODD parent wants, they're against. So they fight medication, they fight instituting a program, and oftentimes you can't institute either medication or this very comprehensive behavior management just because the other ODD parent is actively thwarting it.
Can you talk about ODD in adults? There are a few adults on the webinar who have been diagnosed later in life and are looking back and seeing that their oppositional behavior has affected the course of their relationships and careers. Is this something you see in your client base?
Yes, I do. And again, usually it's the kid is ODD, and in the process of working on a treatment program for the kid, it comes out that the parent has been fired from multiple jobs because they constantly are telling their boss what an idiot they are and how they don't know what they're doing, or they got kicked out of the military because they were, quote, unsuitable to remain in the military, that sort of thing. They've had multiple divorces, etc. And so it's important to help that. Again, the readiness is all. The person has to say, all of these things have happened throughout my life. I am the only common denominator. I'm tired of living like this. I want to do something. Otherwise, again, the ODD, child, adolescent, or adult, can thwart everything you do merely by doing nothing. This is, again, it's getting an adult to actually engage and remain engaged is a very difficult thing, because all they have to do to completely defeat everybody is do nothing. It's a very, very difficult condition to treat. And
in
the
adults,
earlier you do it, the better.
Right. Yeah, a lot of questions about that. What happens to kids who aren't treated? Do they outgrow it? Does it get worse? What's the prognosis for children who have ODD?
The prognosis is it continues into adulthood, and I hit on this a little bit earlier. Again, very round numbers. About 1 in 4, suddenly it just disappears. It goes away. Just as it didn't come for any apparent reason, there's no apparent reason why it leaves. 40% of people, it gets progressively worse lifelong, and they proceed from oppositional defiant to conduct disorder to antisocial personality, which is a fancy way of saying this is our criminal class. These are the people who occupy our prisons. Again, very, very negative outcome. And about 30% of people, 35% of people just continue with the oppositional defiant disorder their entire lives. So it's a non-remitting chronic condition for most people.
What are the signs that a person has moved from ODD to conduct disorder?
Again, it's that everything has gotten significantly worse. I'll read you the diagnostic criteria from the DSM-5, and it falls into 4 basic sections. First one is aggression to people and animals. Often bullies, threatens, or intimidates others, initiates physical fights, has used a weapon to physically harm other people, physically cruel to people or animals, has stolen while confronting a victim, has forced someone into sexual activity. Second group is destruction of property, has deliberately engaged in fire setting with the intention of causing serious damage or destroyed the property of others. Third group is deceitfulness or theft, has broken into someone else's house, building, or car, has lied to obtain goods or favors or to avoid obligations, has stolen items of non-trivial value. And then the fourth one is serious violations of the rules, often stays out at night despite parental prohibitions, is often truant from school, has run away from home overnight for at least a night. Those are the diagnostic criteria for oppositional defiant disorder.
Okay. So it's,
again, much more serious physically
for conduct disorder.
Others.
Right. Okay.
These are
so
bad
yeah,
cases.
you definitely want to avoid that, and that's why you're advising treatment for the ODD early on to keep that from progressing to that.
Yeah. 40% risk of progression.
Wow. Do kids with ODD oftentimes have remorse after their behavior?
They sometimes can.
They can, yeah.
They'll come back and apologize for it, and then do it again.
Right.
But it's something sort of where the parent, one, doesn't trust the apology and even gets kind of pissed off that the kid's coming back and apologizing. It's sort of, who cares if the kid apologizes? He's going to do it to me again in an hour. What does this apology do me? And again, that's where I try and emphasize is that this is hardwired. It is not something that the child has an active choice about. It is an obligatory behavior, and it's always astounding to me that this type of very complex behavior can be coded for in our genes. I mean, that just
right. But there's no genetic test, obviously. Maybe there will be someday. I mean, some
No,
folks
and
are
you're not going
acting.
to do, and you're not going to do spinal taps on everybody either.
No, no. How early should children be diagnosed and or treated for ODD, or can they be diagnosed and treated?
They can, again, there's a childhood onset, usually at about 4 or 5 years of age.
Right.
This is the kid who's been thrown out of 3 daycare centers, that sort of thing. The kid who starts just cursing like a sailor at age 4, that sort of thing. So it's one of those things that you treat wherever there's impairment. Ultimately, this behavior really destroys, not just impairs, but destroys a parental bond. These are hard kids to love, or at least continue loving. And so usually these people end up being estranged from everybody they know, everybody in their family. Again, this is a disastrous condition. And so the earlier you can intervene, the better.
Number of people have been advised to send their children to wilderness programs. Do you have any point of view on those?
Yeah, I've generally found them to be kind of useless. When you look at providing more structure, more rules, and stuff like that, that's what's called a non-specific benefit. It comes from the environment, from the situation, from the structure that other people provide. And so it's kind of universal. Any child, any adult will do better in a predictable, structured, rational environment than they're going to function in a chaotic, unpredictable, out-of-control environment. Non-specific is as if the child is removed from that situation, have they changed? And I really have not seen much in the way of permanent change from these wilderness programs. A lot of these kids end up being sent to military schools where basically they're housed with a whole bunch of other kids who the parents have just found to be utterly intolerable. Again, it's more outsourcing the problem for somebody else to take care of.
Right.
That said, I am a big advocate for parents getting respite. These kids are exhausting. They'll just eat your soul out. So having some time away, especially to renew the bond with your spouse, and not be split by the child, I think is very, very important.
Yeah, absolutely. Can you talk a little bit about finding a therapist? So many people have said, how do I get everybody on the same page about treating the child? One thing I just wanted to point out to the members, people who are listening in, on the Attitude website, on the webinar for Dr. Dodson, on the page for Dr. Dodson's webinar, attitudemag.com/webinars, we put a link to a quiz. It's a self-test. It actually lists the symptoms, and you can answer that, and then you can print it out at the end and take it to a doctor if that helps you have a document to take to a therapist or a doctor to get everyone on the same page about how severe the symptoms actually are. But, I think it is really difficult to get help for people. What are your thoughts? Yeah.
As with just about anything having to do with ADHD, there are very few people out there that know what the hell they're doing. There was an article by Peter Jensen, who's a very famous researcher in ADHD, while he was still at the Mayo Clinic. And what he showed was that the average family went through 11 clinicians before they found one that they thought was competent to treat their child's ADHD. I would submit to you that there are even fewer that have the competency and experience to treat a child with ADHD and oppositional defiant disorder. So how do you find these people? You go to a self-help group. CHAD is the place out there who have been through what you're going through right now. They know who's good, they know who's not, they know who gets results and who doesn't. Start with them. Don't recreate the wheel. And it's not just for the information that you'll get at the CHAD meeting, it's for the support that you'll get. There are fewer and fewer now, but there's usually tough love organizations in most major cities, and you can just, again, Google search them. God bless Google. You can find anything.
Yeah.
There are also, for adults, the National Attention Deficit Disorder Association, ADD.org, is a very good group for adults. And again, you can find somebody there that will be very helpful, who's a year or two out in front of you, who can give you some guidance about where to find help, and also tremendous support. You need support if you're dealing with a child or a spouse or both who have ODD.
Okay. For those of you who asked about CHAD, CHAD is the National Organization for Attention Deficit Disorder. Wonderful resources, CHADD.org. Just an unbelievable resource. Local support groups, helpline you can call. I can't stress enough how helpful CHAD can be to you. So make sure to take advantage of that. What about other treatments? Neurofeedback, biofeedback, diet? People, all want to know whether any of these other techniques can work. Hypnosis, someone just mentioned.
All right. And in doing a literature search for this book you're going to be, I hope, seeing very, very soon, I found nothing on any of those topics. It just hasn't been researched. In general, one can say about ADHD that there never has been any research that shows that what you eat either causes ADHD, makes it work, or worse, or makes it better. There are 2 open-label studies of omega-3 fatty acids that have been able to show, and again, a statistical improvement with omega-3s. Again, it's something that you can find when you run the numbers, but in terms of actually seeing something dramatically change out in the real world, nothing in the food realm has been found to either make things better or worse. It's kind of neutral. And we have probably 100 studies now looking at diets, either subtraction diets or addition diets or megavitamins or health foods or only natural foods and things like that, decreasing sugar. None of those things have been shown to have an effect upon ADHD.
Okay.
It just hasn't been studied with ODD.
All right. Last question. Let me see. There's so many questions here. Is there, do you know, does the research show any link between early trauma or neglect and development of ADHD or ODD?
I am not aware that anybody's looked at that.
Okay.
I haven't been able to find it.
It could be, I know early malnutrition, and this is among children adopted from orphanages, certainly can be linked to ADHD. I don't know that there's any evidence on ODD. Can you talk a little bit more about Dr. Barkley's books and his materials? Because I think he's a huge resource for families with dealing with ODD.
Yeah. Dr. Russ Barkley has been the theoretician in ADHD for the last 25 years. He's now retired. He does do lectures and things like that around the country, but he's not actively doing research anymore. His major theory of executive function deficits in ADHD, unfortunately, has led nowhere. It hasn't led to therapies. When other people have looked at it, very inconsistent findings. So when the folks who did the DSM-5 reviewed executive function deficits to see if it had anything to offer to the DSM-5, they said they found nothing it had to offer. That said, he is a tremendous resource on defiant children. His book is the standard book. It's got a big, bright red cover. What he did was he went out and spent an entire year at the University of Oregon in Portland, Oregon, was where most of these techniques were developed, pioneered, tested, etc. And so basically what that book is he wrote up his notes from a year that he spent in Portland. And it's a very good behavioral modification program for prepubertal children.
His book is The Defiant Child, I believe. Right. And yeah, he is a great resource. Just before we close, Dr. Dodson, do you have any words of hope? A number of people have posted that this just sounds so grim. You know, the genetics and the fact, the description of the behavior. Do you know? Have you seen cases where kids have behavior's been turned around or helped?
Absolutely.
Offer anything of hope to our audience?
Yeah, it's. I know most parents don't want to hear this, but medication. Medication is the treatment modality that has a track record of dramatic benefit. It's where everybody ought to start, not the treatment of last resort when everything else has failed. Again, because these are more than misbehaving children. These are the kids from hell. And they are hardwired to defeat anything that the parent tries to do. That's what makes them different from just misbehaving children. This is something that's neurological, genetic, biological, and things that are neurological, biological, genetic don't respond to behavior management. It makes about as much sense as trying to lower a fever with a behavioral technique. It just doesn't work. And it doesn't work with ODD. It doesn't work with ADHD.
So medication.
The behavioral techniques in ADHD have never once been able to show that they have detectable lasting benefits. Medication is where you start, gets you in the game with a child who can cooperate with you rather than defeat you. You have to get in the game on a level playing field, and you do that with medication.
Okay. Thank you so much, Dr. Dodson. It's been great. In response to the question from about upcoming webinars, June 12th, ADHD adults and learning disabilities. Do you have one? And what do you do about it? June 17th, how to lose the shame. ADHD adults, how they can rise above shame and guilt, with Stacy Juris, who's our attitude blogger, who's just really hits the nail on the head about the living with the shame and guilt that comes with adult ADHD. And finally, on June 24th, Battle of the Bulge, losing weight the ADHD way with Dr. John Fleming. ADHD adults are known to have a difficult time losing weight, and for obvious reasons, organization skills. So we hope you'll join us. Thank you again, Dr. Dodson. Thank you, everyone, for joining us today. And please log on to attitudemag.com/webinar and take advantage of the resources that will be there. Thanks again.